Honorable Chairpersons and learned audience, Assalamu alaikum and good afternoon. I'll talk on challenges in changing the trends of management of breast cancer. I have nothing to disclose. Management of breast cancer from our perspective was once straightforward. If FNSC report of a lump is malignant, then the treatment is mastectomy, followed by chemotherapy, radiotherapy, and hormone therapy. Though more than 40 years ago, in Milan trial and NSCBP BO6 randomized control trial, 20 years follow-up showed that there is no advantage to mastectomy over BCS in early breast cancer. Still, our mainstay of surgical management is mastectomy. So there are a lot of changes which we have to adopt. Now let's see what are the changing trends in our perspective, because this perspective is not the same like the developed countries. First, to know the biology of the breast cancer, then the surgical advances, and then shift to adjuvant to neoadjuvant therapy, the clinical registry, genetic testing, and the multidisciplinary team approach. Regarding molecular biology assay, we must know the biology of the tumor to offer the individualized treatment of breast cancer to our patients. And to do so, we must replace the FNSC by core needle biopsy, and if it's better if we can do it by ultrasound guidance. And by ultrasound guidance, we can also do the placement of the marker and the guide wire for BCS. But doing so, what are the challenges? The challenges are cost issues or financial excuse and less availability of appliances and investigation facilities. Next, from adjuvant to neoadjuvant therapy, because we offer preoperative systemic therapy not only to the inoperable breast cancers, but also to the operable breast cancers, especially in HER2 positive and triple negative breast cancers, and also to the large breast tumors, the patient who wants breast conserving surgery. And in node-negative, clinically node-negative diseases likely to become clinically node-positive diseases likely to become node-negative after NSCT, by which we can offer de-escalation of the axillary surgery. But we should not be over-enthusiastic in using the preoperative systemic therapy. So we have to know who are not the candidates for preoperative systemic therapy, like patients with extensive in situ disease and patients with a poorly delineated extension of tumor. So in this regard, the challenges are issue of discontinuing the treatment by the patient after good response to the therapy. Now look at the surgical advances, starting from the Holstedian radical mastectomy to modified radical mastectomy, then breast conserving surgery, and last to the oncoplastic breast surgery. Now I'll show you some of the works we have done in our settings. Round block technique with medial mammoplasty in carcinoma breast patients. Then hydrogel marker was placed in in patients before NSCT. Guide wire placement before surgery, sentinel node biopsy, specimen marked and sent for frozen biopsy. And in another case, crescent mammoplasty in a breast cancer patient, round block with lateral mammoplasty, wide local excision or BCS in breast cancer patients, another patient with wide local excision, another patient with wide local excision where marker was placed, which is seen in ultrasound, and the follow-up picture after 2 weeks and after 4 months. Another case of lateral mammoplasty and another case of wide local excision. We have also done some oncoplastic breast surgeries with the help of our plastic surgery colleagues. In this patient with locally advanced breast cancer, we have done LD flap with the help of plastic surgeon. And we have also done parascapular flap in another locally advanced breast cancer patient. This is the picture of a post-BCS, post-radiotherapy complication patient, in which patient we have also done oncoplastic breast surgery using the parascapular flap with the help of our colleague. Another case of oncoplastic breast surgery where parascapular flap is done in a patient with malignant phyllodes. In this regard, the challenges are failure to convince the patients for BCS or OPBS, lack of knowledge of the patients and the public, lack of updated knowledge of health professionals, and lack of faith of our patients in us. And this lack of faith of the patients in us, I mean that as we are not talking in same language, that is, we are not following the same guidelines, so the patients become confused by hearing different language from different surgeons or oncologists. Regarding non-palpable breast lesions, we cannot offer stereotactic biopsy and lymphoscintigraphy in our settings. We cannot also offer the use of gamma probe and a specimen radiograph and sentinel node biopsy in dual technique. We only offer sentinel node biopsy using the methylene blue dye. We also cannot offer skin-sparing mastectomy, nipple-sparing mastectomy, and the implant. So in this regard, the challenges are lack of logistical, instrumental, and technical supports, and lack of advanced training in our settings. Though we have so many constraints, we are trying to offer the best possible treatment to our patients as we are doing the MDTs, which guarantee the best care through the entire course of the disease of the patient. And we are also trying to maintain some clinical registry because it provides concept and quality indicators and helps in National Cancer Control Program and facilitates research activities to support decision making. Though in very few in number, we are trying to do genetic testing in some of our high-risk patients so that we can offer risk-reducing surgery in our high-risk patients. We are also doing CTC, that is circulating tumor cell or liquid biopsy in some of our patients because we have got a very prestigious grant from our government where we are seeing the CTC as a prognostic marker. So for sustaining and expanding these efforts, we need support from policymakers. We have to establish formal title for the breast surgeons along with adequate training and certification. Strategies are needed to educate our colleagues, need awareness through counseling and media outreach, and securing financial and logistic support from the government to meet these challenges. Now let's see the surgical perspective in Bangladesh. To keep pace with the developed countries, huge progress has been made in surgical practice, particularly in laparoscopic and minimally invasive surgery. Even robotic surgery has been started, which was once a distant dream. However, in the field of breast surgery, we remain stuck in the past. Regarding breast cancer management, we always tend to focus on traditional approaches. If we can evolve our practices in other areas of healthcare, why should breast cancer management be any different? So our recommendations are, we should shift our mindset and we should stick with the updated guidelines. We should ensure early diagnosis, reliable radiology and pathology services, and access to healthcare facilities, and to earn the patient's trust. Also, advocacy and involvement of civil society is needed. Collaboration is very important because it leads to bridging the gap in resources and knowledge, helps in getting the training and access to cutting-edge technologies, and sharing of best practices by implementation of international guidelines. So in conclusion, disseminating updated knowledge, transitioning from the traditional practice, advanced training, international collaboration, and creating awareness could pave the way for better management outcome and improved survival rates and quality of life of the women with breast cancer. Acknowledgement, and thank you everyone for listening.